Okay, please start. Ankita, you can start.
Okay.
Good morning, everyone, and welcome to today's webinar on pelvic floor dysfunction. My name is Ankita Talreja, and I'm assistant professor in community health at Myers Physiotherapy College, Talegaon, Dabhad. I'm pleased to introduce today's speaker, Dr. Signa Mehta ma'am. Signa Mehta ma'am is certified by American Physical Therapy Association in 3 obstetrics and AMP, 3 pelvic physical therapy courses in USA in advanced techniques in labor support, fundamental pregnancy and postpartum physical therapy, advanced techniques pregnancy and postpartum physical therapy, incontinence, pelvic pain, bowel dysfunction, and she has been in teachers training in pre and AMP and postnatal exercises by the great Elizabeth Noble. She is trained from more than 20 international renowned physiotherapists like Brain Mulligan, Jenny McConnell, and she has completed level 3 in kinetic control, and she is also certified by the McKinsey Institute. She was also offered scholarship by APTA for pelvic pain and bowel dysfunction courses in 2019 in USA. Ma'am has conducted more than 30 workshops in obstetric physiotherapy for physiotherapy students and AMP and the clinicians. When it comes to clinical expertise or the experiences, she has been treating thousands of the orthopedic patients, elite athletes, pregnant, postpartum women, and the women with the pelvic floor problems for more than 40 years. And the list of her works goes on. So let's start with the webinar. A small note, if you have questions for the speaker, please free to send it on the chat. We'll be answering the questions at the end of the session. Now we start the seminar, welcoming our speaker, Signa ma'am. Ma'am, over to you.
Okay. Thank you so much, Mars, for inviting me, and Ankita for such a beautiful introduction. And I'm so happy to meet all the principal of your college and all the faculty members, and of course, all those who are listening in to us today. So I will begin my talk. Okay, so pelvic floor dysfunction could happen in both males and females, but for today's presentation, to make it easy to understand, I will be talking to you about the female pelvic floor. The examination and management of pelvic floor dysfunction spans a very wide field of knowledge and expertise. Accurate diagnosis and successful management can be quite tricky, mainly for 4 reasons. The pelvic floor belongs to different specialities. The colon and the rectum belong to the gastroenterologists and the colorectal surgeons. The vagina and uterus to the gynecologists, urethra and bladder to the nephrologists and urologists, and the whole pelvic floor belongs to, of course, our physiotherapists, psychologists, and nutritionists. Can you put off that screen where you are admitting people and seeing a waiting room? It's just going on clicking on my slide. Can it be put off, Ankita? See waiting room, that one. Can we move it from the screen? Is it possible? So the second reason for the pelvic floor muscles to have a problem of understanding, these are the only group of muscles the patient cannot see visually. Hence, it is difficult for the patient to understand and perceive the problem, unlike all the other muscles in our body. The third reason is very often investigations like MRI, ultrasound, and blood reports are all normal or almost normal. And hence, we do not have any such investigations to fall back on. The fourth reason is the emotional component. All these patients who have pelvic floor problem have a bigger emotional component, and hence it's sometimes difficult to find out the physical disabilities and because of the big emotional component. So let me little talk about the anatomy. So the pelvic floor consists of the urogenital triangle and the anal triangle. And in the standing position, I'm going to talk very briefly about the anatomy. In the standing position, the anterior superior iliac spine and the pubis are in one vertical line, and the urogenital triangle, which I wanted to show you particularly, is horizontal. And all the pelvic organs are on it all the time as long as we stand. The pelvic floor is also a muscular sheet of, is a dome-shaped muscular sheet. Yes?
Ma'am, your slide is not visible. It's only the first slide that we could see.
Oh.
You have to enable the share slide option.
Yeah,
on the
okay,
screen.
I will, okay, let me,
Editing the option on the screen. So we
let
can
me
see
end
the-
show. Okay, you can't see. And I'm, okay. So, yeah, so let me know if you're not able to see. So I'll go from the first
Enable
slide.
editing
And can we
for the
have
first
this, you know, the messages are going on coming on the screen.
Ma'am,
Sorry,
you'll have to
there are
ignore
some,
because
you know,
same thing that we cannot
you
see the
cannot
slide.
remove them because they're constantly flickering and on my slides. And I'm not able to
You'll have
do
to
anything
minimize it
about
from
it.
your end,
Can you
ma'am.
do anything about it?
No, you'll have to minimize it from your end. On the right hand side, you'll see the minimize option. Just minimize the participants ka list.
Okay, okay, I've done it. Oh no,
And the
again it's come. I
communication with the
minimized
chat-
it. No,
Yeah,
I
the
minimized
chat
it,
will
but it's
managing
still.
the chat. You may concentrate on the slide itself.
No, I
Because
minimized
people are
it,
still
but it's
joining,
still
so they'll
coming.
just keep on joining and you will get that notification. But the screen that you are sharing, we cannot see the screen. So you just have to enable the edit PPT option on your screen.
Okay, that I'll yes, I will do that.
Yes.
Yes. The thing is, it's covering the screen. Okay, let me go back to it. Okay, can you see now the screen now?
Yes, ma'am.
Hello?
Yes, ma'am. we can.
Okay, so so I will start from here that the accurate diagnosis, successful management will be quite tricky mainly.
Yes, ma'am.
For reasons. The pelvic floor is shared in the medical field, and therefore the patients don't know which doctor to go to, and also the doctors may not have a collaborative reason for knowing what each of them are doing. So so that's a problem with the pelvic floor. And the other problem is that the patient cannot see the pelvic floor visually, and hence they cannot understand or perceive the problem. The third reason is that lots of investigations and blood reports are often normal. They do not have any abnormality, and therefore, again, another problem that can occur in a pelvic floor dysfunction. And the fourth is the emotional component. So the emotional component is big compared to our knee patients and our back patients, very often in pelvic floor problems. And that's why we have to tackle that very carefully. The pelvic floor consists of two triangles, the urogenital triangle and the anal triangle. You can see my slides now? Can you see
Yes,
the
ma'am.
slides? Okay, so I'm going ahead, okay? So in the standing position, the anterior superior iliac spine is exactly above the pubic tubercle. And what is important to know that the urogenital triangle is horizontal. That's why the load of all the pelvic organs is constantly on that urogenital triangle. The pelvic floor is a dome-shaped structure, and it separates the perineal region below from the pelvic cavity above. It's not only, but it's also a whole lot of organs, the intestines, everything is constantly pelvic. So let's talk about I'm having some
Ma'am,
internet
we can
problem
see
today,
you and now we can
so the
hear you
connection.
also. We can
Okay.
see you and hear you. Yeah, the slide is again started.
Yeah, okay.
Yeah.
So the perineal body is an extremely important part of the pelvic floor. It is a very pivotal role to which are attached all the muscles of the pelvic floor. Can you see the slide? Hello?
Yes, I can see.
Okay. So if you can't see, just tell me because there's some problems that are happening. Okay. So if you immediately let me know if you can't see the slide or you can't hear me or you, okay. So the second layer is the perineal membrane. First, it used to be called the urogenital diaphragm. This is a very strong muscular triangular structure, and the perineal membrane is attached to the ischiopubic rami. The urethra and vagina pass through it, and it attaches posteriorly to the perineal body. The third layer, which is the deepest layer and the layer which we are concerned with quite a bit, is the pelvic diaphragm. It consists of the levator ani and the coccygeus muscles, and the components of the levator ani are the puborectalis, pubococcygeus, and iliococcygeus. So the first question that I would like to ask the audience is, the levator ani are made up of what kind of muscle fibers? Are they 70% fast twitch fibers, 30% slow twitch fibers, 70% slow twitch fibers, or they are 50% slow twitch and 50% fast twitch fibers? The answer is they consist of 70% slow twitch fibers. So they are in a constant state of activity and resting tone, and they can contract to narrow the urogenital hiatus and draw the urethra and vagina and rectum towards the pubic symphysis. The pelvic floor muscles are extraordinary multitasker. Not only they support the pelvic organs, all the pelvic organs, but they prevent fecal and urinary incontinence. They help in voiding. They allow childbirth, sexual function. They are very important part of the pelvic stability and lumbar stability, and they're very important part of our breathing. So the pelvic floor and the respiratory diaphragm are functionally and structurally bound together by facial and muscular connection of the psoas. Hence, have a very close connection with each other. So when we take a long expiration, all of you listening to me can take a long expiration. When you do that, you will automatically feel your pelvic floor rising. So they have a very close connection. The pelvic wall muscles are also very important. The piriformis and the obturator internus are very much part of the pelvic floor. So this is another view where you see the lateral obturator internus and piriformis muscle and the pelvic floor muscle connection. Pelvic floor muscle dysfunction. What are the symptoms that you see in such patients that we will come across? Would be urinary incontinence, it could be stress incontinence, it could be urge incontinence, or it could be a mixed incontinence of both of them. Or they could be bladder storage symptoms, or sensory symptoms, or voiding post-micturition symptoms, or symptoms of pelvic organ prolapse that we would see with the muscle dysfunction. Let's look at the examination of the pelvic floor. Before we treat a pelvic floor, we must take a thorough history, and also we must know how to examine a pelvic floor. This is the official statement of the section of Women's Health of APTA. It says that examination of pelvic floor muscles is consistent with physiotherapy practice. It complies with the performance of elements of neuromuscular function as an aid to the evaluation and treatment of a specific medical condition. This is important to tell people who are not familiar that in physiotherapy practice, we do treat, we do examine the pelvic floor both externally and internally. So as far as history, we take history of every single patient that comes to us. The first thing that you do is take an informed written consent for evaluation and treatment. And listening to the patient carefully is extremely important, especially in the pelvic floor dysfunction patients. And a thorough biopsychosocial history is also essential. It should also include past and present medical, surgical, and musculoskeletal history. It does require a multidisciplinary approach because we are not proficient in all aspects of treating the pelvic floor. The site, duration, nature, precipitating factors, and effect of activity on symptoms must also be assessed. So we always begin examination with a visual observation of the patient in crook lying. We observe for all of these things that I've written down here, and once we observe, we note it down. The next thing we test is the sensation and reflex testing. And for that, we can use a hard end of a cotton swab very gently. We can touch the different parts of the perineum and find out if there is any problem with the sensation. Are the sensations fished? Is there hyperalgesia, or they are normal sensations? Anal wing test is an important part of the examination also. And we to check the reaction of the external anal sphincter muscle. It should have a normal, when we touch the external anal sphincter muscle, there will be a reflex contraction, and that is why it's called an anal wing. So what are normal pelvic floor muscles? We must first know what are normal before we start treating the abnormal. So there should be always a voluntary contraction, and not only a voluntary contraction, but there should always be a squeeze and a lift. Whenever we do digital palpation, we should feel a squeeze and a lift in a normal pelvic floor muscle. The voluntary relaxation should also be complete. That means we asked the patient to contract the pelvic floor, and then we ask them to relax the pelvic floor. When we ask them to relax, it should be a complete relaxation. Involuntary contraction and relaxation are both present. So we ask the patient to cough, and we find that the pelvic floor contracts and then relax automatically. There should be no movement of the pelvis, no contraction of the gluteals, adductors, nor any overuse. There should be no breath holding, and there should be moderate co-contraction of the transversus abdominis. So this is a normal pelvic floor muscle. What is an underactive pelvic floor muscle? A muscle that cannot voluntarily contract when contraction is appropriate or attempted, or it is action compared to a complete absence of a contraction. Overactive, the PFM do not relax, or it may even contract when relaxation is functionally needed during micturition or defecation. These are the people who have the problem with the overactive pelvic floor muscle dysfunction. And then we could have non-functioning, where you do not palpate any action at all of the pelvic floor. We must also screen every patient for pain, especially if they come with us with a complaint of pain. This can be done with a Q-tip touch test of the introitus, and it is recommended to do this test prior to any internal examination. So the next thing that we do is palpation of the superficial muscles. Earlier, I did talk about the ischiocavernosus, the bulbospongiocavernosus, and the perineal body and the superficial transverse perineal. We can palpate them gently and find out the feeling. The feel of it is important. Then after we've done all of these, we can do the vaginal digital internal examination. Very often, for many days, when the patient comes to us, we are unable to do an internal exam. It is very common. Once they become very comfortable with us and we need to do an internal exam, then we start doing. We do not do an internal examination very often, and this is the question actually I wanted to ask you all, that an internal digital examination to identify correct PFM contraction. Which of these answers is correct? Perform correct PFM contractions with verbal instruction, that's good enough, or you need an internal digital exam to identify the squeeze and lift components. Third one is correct. We do need an internal digital exam to identify the squeeze and lift components of a PFM contraction. Without that, just with the verbal instruction, we cannot, and with just an observation, we cannot make out whether the PFM is contracting correctly. So in internal exam, can you have your audios on mute, please? Thank you. Internal exam is not recommended if patient complains of dyspareunia, that is difficult or painful sexual intercourse, vaginismus, spasm of the pelvic floor muscles, or history of pelvic trauma, or if the patient does not give consent for internal pelvic exam. I do not do internal pelvic exam in unmarried girls who have never had an intercourse, and so that policy, and otherwise you don't do it. If somebody's audio which is not muted, everybody is requested to please mute their audios. Thank you. So the internal vaginal digital palpation, the pelvic, useful examination, and it helps us physiotherapists to understand, teach, and give feedback to patients. The advantage of such an examination is that we gauge pelvic floor muscle strength, endurance, anatomical changes, symmetry of contraction, muscle tone, as well as any painful areas if present. I again request whoever's voted, please mute your audio. Thank you. It has a good intra-rater reliability, but it is only fair in inter-rater reliability. Hence, only a digital palpation is not good enough for research purposes. So the Laycock scale is extremely important for judging the muscle scale, and it talks about the power of contraction 0 to 5, 0 being contraction of course, and 5 being a powerful cue. Time for which maximum contraction can be sustained. How many repetitions? Up to 10 maximum voluntary contraction should give in a normal, and the fast twitch fibers are extremely important. So number of 1 second contraction and full relaxation in 10 seconds can be assessed. Elevation, lifting pelvic floor muscle towards the pubic bone and head, both are present or absent. It's extremely important to have that lift. Co-contraction of the transverse abdominis is also expected, and the timing of involuntary PFM contraction, whether it is present or absent. The slide is not moving.
The screen has gone off.
Again, it has gone off. Yeah, that's why the slide was not moving. When did which slide did you see last?
The group lying digital examination slide.
Laylock perfect scale.
Laycock perfect scale. Okay.
Can everyone please mute yourself?
I think can you hear me?
Yes, ma'am.
Yes, ma'am, we can.
No, I think I'm not getting the screen share, this thing only.
Ma'am, on the down of the screen, can you see it? Ma'am, I'll do it for you. 1 second.
No, I have clicked on it. I'm not able.
Ma'am, I'll share the screen for you.
Can you see it now?
Yes, ma'am.
Yeah.
Yes, ma'am, we can.
Okay. So this this you could see. This you could see, right?
Yes.
Okay. So a measurement of pelvic floor muscle contractile activity would involve visual observation, digital palpation. Surface EMG can be used for finding out the contractile activity, manometry, dynamometry, real-time ultrasound imaging, and MRI. These are the different things that we can use beside the visual observation and digital palpation that we physiotherapists commonly use. Let's talk about the underactive pelvic floor muscle. The ICS, International Continence Society, has defined it as a situation in which the pelvic floor muscles can voluntarily contract when this is appropriate. Symptoms such as urinary incontinence, anal incontinence, or pelvic organ prolapse. Signs like no voluntary or involuntary contraction of the pelvic floor muscles. Let me talk about this young boy. Now, if this young boy is spraying water in his garden and he puts his foot by mistake on the pipe, then the water will stop flowing because he is standing on solid ground. But if the same boy is standing on a hammock and then he puts his foot on the pipe, the water will continue to flow. This is exactly what happens in underactive pelvic floor muscle. Port at the dock is a good example of a dysfunction pelvic floor muscle leading to pelvic organ prolapse. With which it is hanging are the ligaments. Now imagine that the pelvic floor muscles become weak. What will happen? The boat will come down and it will hang only on the basis of the ligaments. And of time, the ligaments also become weak. It cannot hold the boat anymore and the boat collapses. This is exactly what happens in a pelvic organ collapse. First, the pelvic floor muscles become weak, and then ligaments are overstretched, and so the pelvic organ prolapse happens. It is also important. Can we again have the audios on mute, please? I can see somebody sitting there with the audio not muted. Can you please mute your audios? Thank you. It is also important to remember that continence depends on the neural coordination of activity between the bladder, the urethra, and the pelvic floor muscles. It's not only the pelvic floor muscles that on which the continence depends. Kegel exercise something I want to talk about because everybody all women practically all over the world know about Kegel exercises. So Kegel exercises was discovered by Dr. Arnold Kegel, and he is the first person to talk about non-invasive treatment for urinary incontinence. But in spite of this path-breaking and commendable work that Dr. Kegel did, the main reason for Kegel exercises to fail, and you always hear a whole lot of people talking, oh, I did Kegel, and it didn't help me. So because it is done wrong, that is the reason why it fails. Also now, because of extensive research and advanced technology, we know much more about pelvic floor than Dr. Kegel did in those days. Now, pelvic floor training is also an important specialization in the field of physiotherapy. So again, a question to the audience, which are the muscles wrongly used during a Kegel exercise? Are they the gluteus, or are they the adductors or the abdominals? All of the above. The answer is all of the above. All of these muscles are very often used wrongly while doing a Kegel exercise, and hence they are not effective. So PFM training for underactive pelvic floor muscles. Carrie Bow, I've trained with her, has done a lot of immense amount of research, and she said that these muscles are like any other skeletal muscles, and therefore they will adapt to strength training like our other skeletal muscles. So when prescribing exercises, usually the slow twitch fibers hypertrophy more quickly with exercise training, and a greater effort is required for the fast twitch fibers. The first thing that you teach for correct pelvic floor contraction is the motor learning. Motor learning is the correct way of contracting. So as I told you earlier, it has three components: the squeeze around the pelvic openings, inward and cranial lift, and lift towards the pubic symphysis. This is the first step towards teaching the correct pelvic floor contraction. And then, of course, you teach them strength training, endurance training, and coordination training. Another way to improve correct PF traction, track other circular muscles. This is an interesting research that I came across. So if you make a round mouth, like with your mouth, you will find that your pelvic floor muscles also react. So this, of course, recommendation is not, it's only from clinical experience to teach the patients, and it is not researched as yet. So how do we progress with the pelvic floor muscle contraction? The first stage is to teach it correctly and to contract it as hard as possible. Then the second stage to teach the endurance to hold the force. And the fourth stage would be the PFM contraction prior to cuffing. This is called NAC. So before they cuff, they have to you have to teach them to contract the pelvic floor muscles. This is how we go about teaching the patients pelvic floor muscle contraction. And some of them take a shorter time, some of them take much longer. We can also add vaginal cones and teach them sustaining a contraction for a longer time, as I told you before. And in athletes, we teach them contractions with shorter resting periods. We increase the speed of the contraction. We increase the number of repetitions they can do in one go. And in different positions, very important to teach them not only in crook lying, that's the one position we can begin with, but we have to teach them in different positions, and also PFM contraction during workouts, and increase frequency and duration of workouts gradually, especially applicable to all our athletes, and decrease recovery time between workouts. So it's important not only to teach them, but also the maintenance is important. It's a lifelong maintenance. So what I advise them is to do it twice a week at least. In spite of our best efforts, some patients may have difficulty targeting their pelvic floor muscles specifically. We can help them by identifying, we can give them biofeedback methods. The simplest one is a mirror. We can put a mirror in front of the perineal area, and so that the patient can see what they are doing. And of course, we have the very sophisticated biofeedback device, and electrical stimulation can be used in certain cases. So research, a lot of research is now done. This is just a few research that supports PFM training. Let's talk about the overactive pelvic floor muscles now. It is defined by ICS as pelvic floor muscles which do not relax or even may even contract when relaxation is functionally needed. For example, during micturition or defecation. One of the rogue muscles is puborectalis, which prevents the person from having a regular bowel movement. Overactivity of the pelvic floor is less recognized and not as well understood as pelvic floor weakness, and its clinical presentation can be far more complex. It has not been clearly established whether pain or other symptoms in the pelvic floor muscle causes the overactivity or overactivity causes pain or other symptoms. So overactive pelvic floor can be found in persons having interstitial cystitis, irritable bowel syndrome, endometriosis, patients having just stress, constipation, functional constipation, physical or emotional abuse, habitual postural dysfunctions, hemorrhoids, orthopedic joint malalignment. And it could manifest as low back pain. Many of our low back patients don't get better. They may be having a pelvic floor problem. That's why it is important to not only have women's health training, but extensive training in all musculoskeletal areas of physiotherapy. Hip pain, coccyx pain, urinary incontinence, incomplete emptying of the bladder, slow flow of urine, urinary urgency, urinary frequency, painful urination, pelvic pain, painful sex, and vaginismus. So if the pelvic floor muscle is active or shortened, you will find that urogenital hiatus may be narrow. On examination, you will find that that incomplete or absent relaxation after contraction of pelvic floor muscle may be present, may be there, or the bearing down may be absent. Perineal body may be displaced anteriorly or superiorly, and perineal movement may be absent due to elevated resting tone of pelvic floor muscles. Anal reflex may be absent, and hyperalgesia to touch. So we have to be very, very careful about the examination. Initial internal digital palpation is best avoided. And if done, it has to be very gentle, and we have to be very sensitive to this. PFM tone assessed by pressing a finger into the muscle belly. Stiffness and elasticity is determined by ease of muscle indentation and return to original shape. We are pretty good at this for external muscles in our body, and this is exactly the same way where we can assess the PMM tone by digital palpation. The physical examination should also include assessment of structures that have the potential to refer pain to the pelvic floor muscles, or pelvic floor muscle pain to these structures. So we not only have to examine the pelvic floor muscles, but we have to thoroughly examine the lumbar spine, the pelvic girdle, and also the potential triggers to pelvic pain, like the obturator internus, the gluteals, the psoas, the abdominals, piriformis, adductor, and also check for pudendal nerve entrapment. Let me briefly talk a little about chronic pelvic pain. So CPP is defined as a non-malignant pain. It should last at least for 6 months. It is localized to the pelvis, anterior abdominal wall, or at or below the umbilicus. It radiates to the top of the thighs or genital region, and there's no proven infection or other obvious pathology. The 4 most commonly diagnosed etiologies according to the ACOG is endometriosis, adhesions, irritable bowel syndrome, and interstitial cystitis. So how do we manage an overactive pelvic floor? It has to be a collaborative, multimodal approach by gastroenterologists, gynecologists, nephrologists, urologists, physiotherapists, psychologists, and nutritionists. Whoever needs to be consulted must be consulted. The patient is advised lifestyle modification like improved sleep patterns. Positive reinforcement is extremely important. Stress reduction techniques have to be taught, dietary modification from a nutritionist, and a general exercise program must be given to these patients, as many of these, because of pain, they become deconditioned. What about physiotherapy management? 85% of patients with CPP or overactive pelvic floor muscle present with dysfunction of the musculoskeletal system. So we have a big role to play. The most promising modalities for treating this are the manual therapy techniques, which we have all been familiar with, for reducing the muscle tension. What are the manual therapy techniques we can use for the pelvic floor muscles? So we can use the levator ani trigger point release. We can use pill rolling and stretching of the perineal body, cross finger stretch of the superficial pelvic floor muscle. We can also use our manual therapy techniques on obturator internus, gluteals, adductors, thoracic paravertebral muscle, lumbosacral paravertebral muscle, posterior thigh, sacral and perisacral edges, quadratus lumborum, piriformis, and muscles of pudendal distribution. We also should do a whole body postural correction, and PFM exercises should make them aware, should consist of awareness, relaxation, proprioception, re-education, and contraction. The respiratory diaphragm release is also extremely important. Voiding and defecation retraining, dry needling, hot cold pack, dilator. We can use dilator in case of vaginismus and such problems. Scar tissue massage techniques. All of this physiotherapy management helps them to feel much more comfortable. It may not treat their endometriosis, for example, but the patient becomes subjectively much more comfortable because of the musculoskeletal problems associated with these CPP problems. Biofeedback can also be used as an adjunct, and we should always ensure that correct PFM contraction by perineal observation and digital palpation is happening during the biofeedback. It is very useful in case of SUI, urge urinary incontinence, fecal incontinence, constipation, and pelvic pain. When to refer? It's extremely important to know when should we refer these patients. Do we all keep treating them all the time? Not at all. Both in the case of an underactive and overactive pelvic floor, if the patient has directly come to us for treatment, it's advisable to refer, consult another specialist whenever we feel the need to. Also, if there's no response to treatment within a reasonable time frame, please refer to an appropriate specialist. This will ensure the best treatment for the patient, and pelvic floor dysfunction requires always a collaborative treatment regimen most of the time. I want to tell my young physiotherapists in the audience, especially about some of these bladder habits that we have, especially at a young age, which lead to dysfunction. Delaying toileting too long can overstretch bladder, leading to atonic bladder. So many of us will not use the public toilets, and it can overstretch the bladder. Hovering over the toilet does not allow adequate relaxation of the pelvic floor muscles, which we all women do often because we do not want to sit on the seat of the commode. Bearing down to initiate stream or complete urination, some of us do this. So this is also not advisable. Not allowing time for full bladder emptying, voiding just in case, or preventative voiding. That means I have to go for a long trip from Bombay to Pune, and I don't know what the toilet would be like on the way. So I do not drink water from the morning. So, or I go to the bathroom before I leave, even when my bladder is not full, or I'm in a function for 3 hours and I keep going and emptying my bladder just in case. Failing to wipe front to back after bowel movements may lead to urinary tract infections. What are the exercises to avoid for a weak pelvic floor? If a woman has a weak pelvic floor, she should not do certain exercises. Unfortunately, I come across people of all kinds, physiotherapists, non-physiotherapists, people from different fields teaching pelvic floor exercises, and many of them are wrong. Every day almost I come across this. And so we should not do exercises that increase our intra-abdominal pressures. This exerts pressure on a weak pelvic floor, and hence a person with a healthy pelvic floor may get away with it, but a person may weaken a pelvic floor further if she already has a weak pelvic floor. So what are the exercises that we should avoid? A very commonly done exercise is the crunch or a head lift. It increases the intra-abdominal pressure. It also pushes on the pelvic floor downward, especially if it's weak. And exercises like this, where we lift the legs and the upper body together. Bad exercises for a weak pelvic floor. And this one, unfortunately, even physiotherapists teach this. That's the sad part of it. Lifting heavy weights. You see, unfortunately, this woman peed when she had to lift heavy weight. So lifting heavy weights beyond your capacity, beyond the capacity of the pelvic floor, not recommended. If she leaks while running, jumping, and doing other high impact activities, it is better to avoid these activities and teach her pelvic floor exercise and gradually put her back into these activities. A lot of my elite athletes leak while they run. They are fine otherwise, but when they run, they take part in, and one of the worst one is this trampoline jumping. So they have to be taught the exercises and gradually put them into the running or exercise mode. So there's a question which I wanted to ask you. Should we keep our core activated all the time while we are exercising? A lot of us think that, the core is so important that we should keep it activated all the time while we are doing a yoga asana or we are doing all kinds of exercises. Is that true or false? It is false. We should not keep the core activated all the time. It has a natural resting tone, and normally while we are doing an exercise, there should not be any leak. If there is a leak, we first have to treat it. We cannot keep the core muscle strongly activated all the time throughout our exercise, 1 hour or half an hour of exercise. Some of the most common reason why our overactive or hypertonic pelvic floor is seen in a healthy individual, in a young individual, because they hold on to their core muscles. Throughout, they've been told that it's important to keep, and we see this a lot in our celebrities. If you look at the celebrities, they are using they are pulling in their abdomen all the time. They also pull in their abdomen while they're exercising, and that leads actually to an overactive pelvic floor. You have to let go. Avoiding public toilet for hours and high levels of stress, fear, or anxiety can cause muscles to reflexively tighten. It is surprising when I see these women in labor. The moment they're getting pain, the first muscle they tighten up is the pelvic floor. If I see that I'm going to be hit by somebody, I immediately, reflexly tighten my pelvic floor. So pelvic floor is a very, very sensitive muscle. And if you're in a high level of stress all the time, or fear of anxiety all the time, then you tend to end up having a hypertonic pelvic floor. Some of the ways you do not for exercises. The ways to pelvic floor exercises. Can you see, girls?
Yes, ma'am.
See? You can see, right?
Yes.
Okay. Yeah, can you see? Yeah. Some of the ways not to do your pelvic floor exercise include stopping and starting your flow of urine every time you go to the toilet. A lot of people test their pelvic floor strength by doing this. That's not a good idea. Tightening your muscles quickly and relaxing and doing hundreds of these per day. Quality is more important than quantity. If the quality is not there, no point in doing these hundreds of muscles. In fact, you end up with a hyperactive pelvic floor maybe. So while doing pelvic floor exercise, I repeat, There should not be any movement of the pelvis. If you're doing it in the sitting position, your body should not go up and down. It does go up and down if you're incorporating your gluteus with the pelvic floor contraction. You do not squeeze your legs together and use your adductors when you're doing a pelvic floor exercise. You do not hold your breath, and you do not tighten your abdominals really hard. There's huge scope of practice for us physiotherapists. We are the musculoskeletal specialists. We may not be able to treat the dysfunction in its entirety. Like we cannot treat every aspect of, say, an endometriosis patient. But most patients with both underactive and overactive pelvic floor have associated musculoskeletal issues, which when we address, there's a big decrease in their symptoms and suffering. And hence we physiotherapists have a huge role to play as part of a team managing pelvic floor dysfunction. And this is my personal experience. When we decrease their musculoskeletal problems or symptoms, they feel much, much better. So can all physiotherapists treat pelvic floor dysfunctions? No. To be a pelvic floor therapist, we not only need to undergo special training in various aspects of pelvic floor dysfunction, but also in various manual therapy techniques. So we have to be a master of both. And last but not the least, be very thorough with the neuromuscular anatomy of the whole body. All these three things are very important to treat a pelvic floor problem from a physiotherapist angle. So what's my take-home message? We are still discovering new things about the mystery of the pelvic floor muscle. We still do not know a lot, so the learning must go on forever. Many a times a day, I realize how much my own life is built on the labors of my fellow men and how earnestly I must exert myself in order to give in return as much as I have received. Quote from Albert Einstein. Thank you so much.
Thank you, ma'am. Thank you so much.
Okay, I'll do the shop stare. Okay. Okay.
Hello, ma'am.
I have.
For the wonderful session. Hello.
Thank you. Thank you. Good to see you.
Yes, ma'am. I'm Dr. Nitin Nikhade,
Hello.
professor in Myers Physiotherapy College.
Okay.
So there are
Nice.
some questions in this session,
Yes.
ma'am. So let
Yes.
us have some question answer session.
Sure.
Our question is how to assess pudendal nerve development, and similar question is asked on how to differentiate between pudendal neuralgia and obturator nerve involvement. How to assess pudendal nerve
We have to know the anatomy. Where does the obturator nerve? I would ask the participant asking the question, if she knows the anatomy, she would be able to answer this question herself. So obturator nerve supplies which area of the body? So if she knows that, then that is the area you palpate, the inner thigh area. Okay, and we check for sensations. We check for all the neurological tests that we normally do for a nerve. And same thing with the pudendal nerve. Pudendal nerve is tested medial to the ischial tuberosities. You know, we are going a little into detail, and it's a little difficult without the hands-on, you know, in a webinar to teach something like this. But it is, if somebody is lying in the crook-lying position, you can feel externally the pudendal nerve distribution medial to the ischial tuberosity. And of course, you can do an internal examination and palpate the structures supplied to the pudendal nerve internally too.
Okay, ma'am. Second question is, what are the recent updates in electrotherapy for pelvic floor dysfunction? Recent advances in electrotherapy.
So the recent advances, of course, our biofeedback most of the time, and of course As I said, we can use a manometry or a dynamometry for the squeeze pressure, but it gives only the strength of the squeeze. It only checks. So basically, we also ultrasound imaging techniques give us a good idea of pelvic floor activation. So we can do that checking also. MRI is another thing that can be checked for pelvic floor problems. So these are all, and of course, good old, but I rely a lot on my digital palpation. Like we do as physiotherapists, when we, with the moment we observe something, we palpate something, we come to know a lot more. So, as physiotherapists, I think that should be the big area where we come to know a lot about the status of that patient.
Okay, ma'am. Same question on electrotherapy. What is the dosage of electrical muscle stimulation in pelvic floor dysfunction?
Okay, I am not a big electrotherapy person. Okay, I am more into manual therapy and those kind of techniques. So I wouldn't be the best person to answer that. It's all available on literature, so it's not something that is. I can, I mean, you can always find it out, but if you can't find out, I can always find out and tell you the exact electrical stimulation required. I always prefer our manual techniques. They work very, very well.
Okay, ma'am. Next question is role of Pilates in pelvic floor dysfunction.
So Pilates is good, bad, ugly. It could be anything. So Pilates, whom is it taught by? Okay, is that Pilates instructor also a pelvic floor therapist? Yes or no? So if the Pilates instructor is not a pelvic floor therapist and has no clue of what is happening to the pelvic floor, very often Pilates, they are asking them to constantly contract their transverse abdominis or the core, and as a result, these people can end up with a hyperactive or an overactive pelvic floor muscle. So, so as I said earlier, while exercising, it has to be contracted and left, contracted and left. It cannot go on being contracted all the time. So the Pilates instructor who is doing the Pilates is very important rather than the method of Pilates.
Okay, ma'am. Next question is strengthening of which primary muscle will prevent giggle incontinence?
Fecal. Yeah.
Giggle.
So pelvic floor examination, I did not talk about it. We can do through the vagina and through the rectum. All pelvic floor therapists are trained for that, for both examination of the rectum. So the sphincter, how strong is the squeeze when we are doing a rectal examination? How strong is the squeeze? That is one thing that's important. And what was the other question that you asked me?
Is it recommended to empty the bladder prior to pelvic floor exercises?
Yes, it's more comfortable. Yes, more comfortable.
Okay, ma'am. And what is the duration of pelvic floor exercises for pelvic floor dysfunction?
Depends on the patient. Depends absolutely on the patient. There is no, nobody can say that I can make a 80-year-old exercise as long as I can make an athlete exercise, right? There is no rule. So how strong is your pelvic floor? What is the status of your pelvic floor? What can they do? As I said, there's a gradual increase in the strength, and we look at step-by-step improvement rather than the time factor. We do not look at the time factor. We look at the step-by-step improvement in the individual, and it's a very individualized treatment protocol. So there is no time factor that we talk about.
Ma'am, how to teach pelvic floor training for 5 to 10 years age group in case of incomplete voiding?
Again, I'm not a pediatric physiotherapist, so I do not like to answer questions of the kind of work that I don't do. To be very honest, I would not be able to answer that question.
Okay, ma'am. is there any specific scale or questionnaire to find out which type of incontinence it is?
Scale.
Scales and questionnaire.
Yeah, there are so many standard questionnaire, but basically in stress incontinence, when they cough, when they sneeze, when they lift a heavy weight, or when they run or do any physical activity, they leak. That is stress incontinence. Urge incontinence is that when they cannot control their bladder, or they cannot prevent the leakage from happening before they reach the washroom. That is urge. They have a very, very strong, they have to run to the washroom. That is urge incontinence. And stress incontinence is when they cough, or they lift a heavy weight, or they run. That is the time they get the incontinence.
Okay, madam. Last question. When using vaginal cones for strengthening, how to decide how to progress in the next?
Usually you use the bigger ones first for shorter periods, and then you use the smaller ones, and then we can add weights to the vaginal cone gradually to progress with the strengthening.
Is there any criteria to decide to increase that weight, ma'am?
So depends on again the patient, right? So you've started with a larger vaginal cone, and if she's able to hold it for she's moving around the kitchen, say, and she's able to hold it for say a few seconds, then so basically it gives a biofeedback. It gives you a feedback of something there, and how to hold on to it. And then if she's able to easily do it, then you give her a smaller one. If she's able to easily do that, then you give her with weights added. And at some point, of course, internal vaginal palpation and checking. Every time you move on, you check whether she's doing the correct contraction, because sometimes they squeeze all the muscle. They squeeze their adductors, they squeeze their gluteals, they pull in their abdomen, and then they are holding onto that cone. That's of no use. So checking all of these things are very important.
Okay, ma'am. That's all for today's questions.
Okay.
Thank you, ma'am. Thank you very much.
Thank you, ma'am. Thank you for the wonderful lecture, ma'am. As we come to the end of today's webinar, myself, Dr. Anuradha Sutar from the Community Physiotherapy Department, take this opportunity to extend my sincere thank you to Dr. Suchitra Nagre, ma'am, Executive Director of Member Medical College, for being truly an inspiration during the COVID-19 crisis. I extend my humble thank you to Dr. Snigdha Mehta, ma'am, founder member of the Society of Indian Physiotherapists, for introducing us to importance of overactive and underactive pelvic floor function. I take this opportunity to sincerely thank you, our beloved principal, Dr. Snehal Gode, ma'am, for her unconditioned support and constant guidance in conducting webinars. I thank the Department of Clinical Research and Incubation Center, and also the team physiotherapy, that is the teaching staff of Mines Physiotherapy College, for conducting a useful educational sessions. Last but not the least, thanks all the participants for making this webinar successful. Stay healthy, stay safe. Thank you. Have a wonderful day. Thank you, ma'am.
Thank you. Thank you so much. Thank you so much. It was wonderful to speak to all of you. And thank you, Ankita, and thank you, Dr. Gode, for giving me this opportunity. Thank you.
Thank you, ma'am.
Thank you. Thank you.
Okay.
Thank you.